Good afternoon, everyone. How are you today? We are starting promptly on time since this is being recorded and live streamed, so thank you for being here and being seated and ready to go. We've got 1 hour, and I have 82 slides. Needless to say, I'm not going to go through each one of them in depth. The reason that I have so many slides is that my understanding is the PowerPoint presentation will be included electronically in materials that you can access. And I'd like for you to be able to have this information and then to also have the ability to reach out to me later if you have questions that you want answered. So with that, I'm going to go ahead and jump in and get started. I'll introduce myself to you briefly. And there we go. I'll introduce myself to you briefly. Again, my name is Travis Parker. I'm an area director within our Criminal Justice Division at Policy Research Associates based out of Del Mar, New York. Something you should know about me, though, is I am a remote employee. I do not live in New York. I live in Lincoln, Nebraska, and so I'm about half a country away from our home office. And you'll hear me use some local examples as I kind of go through this presentation. Having a few phone problems. I'm going to try to leave enough time at the end for a few questions. I know some of you have either recently been through a sequential intercept mapping within the last few days, such as in West Palm Beach, Florida, or you are getting ready to go through a mapping here within the next month or so, as is the case in Alabama. So I'm excited to have you all here. A little bit about my background. I finished my master's degree in psychology back in the mid-90s. Since that time, I've worked for multiple years in the State Department of Corrections in Nebraska on inpatient mental health, sex offender treatment, segregation, death row units. I was our county deputy director of behavioral health for about a decade in Lancaster County in Lincoln, Nebraska. I have done some work in managed care, so I've been on the funding side of the coin, and have been with policy research starting as a consultant in 2006, but full-time for the last 5 years. So my background and my passion really is this intersection of behavioral health and criminal justice. I had the opportunity back in 2003 with funding from the Substance Abuse and Mental Health Services Administration to start up our first state's behavioral health jail diversion program. And it was the first time that a county behavioral health system and a county jail in Nebraska teamed up to identify people as they were being booked into the jail at Intercept 2 that I'm going to talk about here, and identify diversion opportunities for people to get back into treatment, services, supports, etc., when we knew that there was a better way than jail for those individuals. So this is not why we are here today. I hope that's not why you came to this presentation. Our focus today will be on adults with serious mental illness who oftentimes have co-occurring substance use disorders, and I'll talk about some statistics here in a moment, who are involved in the justice system. Whenever we go out and do a sequential intercept mapping, we have multiple goals behind that with a jurisdiction, and these are also values that we embrace at Policy Research Associates. We promote and support recovery for all. That said, with the understanding of this, recovery looks different for everybody. Okay, so it would be, I have found throughout my career, my 25-year career, it's very arrogant of me to believe that when I'm offering somebody help that they're at the point of readiness for that help. And so there's a term that I like to use called persistent pursuit, that we may need to offer that assistance to somebody 20, 30, 40, 50 times before they're finally at a point of readiness to accept that assistance. So we know recovery can look like a roller coaster for people at times. Another goal of the mappings using the sequential intercept model is to provide safety and quality of life for all. The people that we're talking about serving, your safety and quality of life, that of your family, that of your neighbors and other community members. We want to keep people out of jail and into treatment where it's appropriate to do so. All right, we know that sometimes there are reasons that necessitate persons being in custody, but where it's appropriate to identify those diversion opportunities, we want to do so using the model. We also want to make sure that when people are going to remain in custody, that we are providing constitutionally adequate treatment in jail, and many jurisdictions really do fall woefully short of that constitutional mandate. And then we want to make sure that as people are being diverted, that we link them to comprehensive, appropriate, and integrated community-based services. That doesn't mean cookie-cutter services. That means each person is a unique individual at a different point of readiness, different treatment, support, and service needs, and we want to identify those opportunities based on where they're at the moment, not where a bed is available or a slot is available, because really that's not doing the person much good, and we're probably looking at a situation where they may recidivate right back into the criminal justice system. How long have we been dealing with this issue? I'm going to show you 3 slides that show that this issue of persons with behavioral health disorders, significant mental health issues, substance use disorders, histories of trauma, often comorbid physical health issues, have been in our criminal justice system. You can see from John Howard in 1777, so right around the time we were becoming a country. I must here add that in some few prisons, and I want to make note in these next 3 slides, the language is not politically correct, okay? Are confined idiots and lunatics. No care is taken of them, although it's probable that by medicines and proper regimen, some of them might be restored to their senses and to usefulness in life. So 242 years ago. 53 years ago, in a publication called Social Problems, an article entitled Policeman as Philosopher, Guide, and Friend. Poor, uneducated people appear to use the police in the way that middle-class people use family doctors and clergymen. That is, as the first port of call in the time of trouble. So we talk about what are those ways when a person is in crisis to avoid dialing those 3 digits of 911. This is something that we were talking about 53 years ago and publishing articles on. 52 years ago in that same publication, a different article entitled Police Discretion and Emergency Apprehension of Mentally Ill Persons. Policemen confront perversion, disorientation, misery, irresoluteness, and incompetence much more often than any other social agent. Do I have anybody that, I realize this is a court managers conference, but anybody that's worked in law enforcement? Okay. So there usually comes a point in time in a law enforcement officer's life where he or she makes that decision, this is the field I'm going to go into. For the 2 of you that raised your hand, when you made that decision, was it because you wanted to be the first person on scene when a person was having a psychiatric crisis? You were the first person to ever nod their head yes to that question. No, okay. Yeah, law enforcement doesn't usually get into law enforcement because they want to be the first port of call when somebody's having a psychiatric crisis. It's typically not why folks decide to go into the field. Yet, that's what we see is that such a high percentage of those calls that law enforcement responds to are people who have substance use issues, have co-occurring mental health, are responding to trauma and things like that. So we need to make sure that as we talk about this model, we're also talking about what are appropriate training points for everybody across the criminal justice system. So let's talk for a moment about the population. When we talk about a health issue in the general population, whether that's mental health, cancer, heart disease, whatever that might look like, and we have a prevalence rate for that in the general population, what do you think happens when we move into the criminal justice system to that prevalence rate? It goes up or it gets worse, right? So if we look in the general population, 4% of individuals have a serious mental illness. So things like major depression, schizophrenia, bipolar disorder. We're not talking about things like situational depression or sleep problems or generalized anxiety. We're talking about serious mental illness. When we move into the criminal justice system, your local jails, that number goes from 4% to 17%. 1 out of every 6 people coming into your local jail has a serious mental illness. That's a public health issue. All right? Anything else that we attached 1 out of every 6 people to, we would say that's a public health issue. And of that 17%, 3 out of every 4 of them also have a co-occurring substance use disorder. Very complex issues. We can't think that they're going to have simple solutions when we're talking about the complex needs of the persons that we're working with day in and day out. If we look at this from the flip side with jails and substance use disorders, 4 out of every 5 people coming into your local jails test positive for some substance if testing's being done. 63% of persons in your local jails have a diagnosable substance use disorder, and 22% of those individuals have a diagnosable co-occurring substance use and mental health disorder. However, only 20% of those individuals, we only have room for 1 out of every 5 to receive some sort of treatment in our jails across the US. So why is it that we're still looking at jails as a solution to this problem? Because it's not. Jails are not the answer to this issue of mental health and substance use and trauma and comorbid physical health issues. And speaking of trauma, we did a study of 20 jail diversion sites around the country. And there were 2,122 participants where we took a look at trauma as a result of physical and sexual abuse. And 2 things surprised us about the jail population that participated in these jail diversion studies. First off, we expected to see fairly significant gender differences in terms of the prevalence of trauma. And you'll see as you look up here on this slide, really the numbers are pretty close between men and women. The second thing that surprised us was the recency of the experience of trauma. If you look in that column that says current, 3 out of every 4 women and 8.5 out of every 10 men indicated that within the 12 months leading up to their most current arrest, they had experienced some form of significant physical or sexual abuse. So what it told us was this: the population that you're working with and seeing day in and day out is not only dealing with significant trauma that occurred sometime in their past, they're dealing with stuff that's happening right now. Right now, and that when they are before you, they are dealing with significant trauma in their life. So we start to pair up serious mental illness, substance use, trauma, and that fourth leg of the stool, oftentimes things like diabetes, heart disease, cancer. And we just keep adding layers of complexity to the problem that we're talking about as we go in and we do things like the sequential intercept mapping with a jurisdiction. So what's one way that communities begin to kind of combat and battle this issue and try to find better ways to serve people with mental health and substance use issues in their system? It's through community collaboration. Unfortunately, when I bring up that word in many jurisdictions, this is the image that pops into people's minds when they think about collaboration across the systems. Fortunately, though, as this old Gary Larson Far Side cartoon illustrates, it's time we face reality, my friends. We're not exactly rocket scientists. Good community collaboration doesn't require rocket science. It requires people who are willing to work together and share resources and people. But there are some challenges to collaboration, such as funding silos. Now, I'm from Nebraska, as I said earlier. When I'm driving across Nebraska, what do you think I think of when I hear the word silos? My kid's detasseling corn right now as I speak to you, all right? He's out there sweating, detasseling corn that's going to go into these silos. What we're talking about are these underground missile silos that people can't see, where we place our funding into because we want to protect it and we don't want people to know about it. We take our best employees and we try to squirrel them away because we don't want other organizations to steal them from us because they do good work. So that can create a competitive spirit across criminal justice and behavioral health partners and entities. We also have to realize we have our own cultures. Our cultures speak a different language in criminal justice and behavioral health. And so one of the things that we can do is to have good cross-training, as it says up top there. If I, as a mental health professional, am being asked to come into your organization to provide some training on signs and symptoms of mental health issues, then in turn I should be asking you to come in and train my staff about what's going on in your piece of the criminal justice system. Some of the benefits of effective collaboration that we've seen come out of the sequential intercept mappings: we see people stay in services longer as they're being diverted from the criminal justice system. We see increased tenure or stability in the community for these individuals, and ultimately we see improved public safety. People committing fewer crimes, people recidivating back into the justice system less and less. How many of you have heard of Maslow's hierarchy of needs? Almost all of you, right? What's at the bottom rung of that pyramid in Maslow's hierarchy of needs? Say that again. Love? That could be included in there, yep.
Basic.
Yeah, basic needs, right? And so one of the lessons I learned the hard way in 2003 when we started our jail diversion program is that I thought, you know what, we've got all these great evidence-based practices that we're going to divert people into, and it's going to be really helpful to them. We're going to save people's lives. They're not going to come back into the justice system. And that was true for the most part. But what our first few participants in our jail diversion program taught me really quickly was, you know, Travis, it's great. You've got all these good services and supports and treatments to send us to. But if I don't know where I'm going to lay my head down tonight, if I don't know where my next meal's coming from, if I have no idea how to access my medications, if I don't at least feel semi-safe or have semi-clean clothes to wear, all of this really isn't going to do me a whole lot of good. So as you think about your community's efforts, whether it's a task force, a committee, a subcommittee, a criminal justice behavioral health group, it's really important that you have the right people at the table. Not just the people that you would normally think of, your criminal justice behavioral health professionals, but people with lived experience, people who have been through your system and can say, this is what worked, this is what didn't work. Family members and loved ones, and especially those people that are help meeting the basic needs of the folks that you're talking about diverting and serving, because again, we've got to help people identify how those basic needs are going to be met. So let's jump into the model here. The Sequential Intercept model was created right around 2005 by 3 people. Dr. Mark Munitz, who's a forensic psychiatrist out of Ohio, Dr. Patty Griffin, who is a forensic psychologist in Pennsylvania, and our former president, who is now retired, Dr. Hank Stedman. And when the model was created and first published in Psychiatric Services in 2006, here's basically what it said. People move through the criminal justice system in fairly predictable ways. I mean, we can look at the justice system linearly from law enforcement contact, being booked into jail, to going to court, to looking at reentry, to perhaps being under the supervision of probation and parole, but we know that that can look a little bit different for some people compared to others. What the model also does is it looks at key points or intercept places to ensure prompt access to treatment. So if somebody is low risk to public safety, is low risk not to return to court, how do we remove them from the criminal justice system as promptly as possible and get them connected with the right treatment, the right services, the right supports? Where are there opportunities for diversion within your community? How do we help people move through the justice system in a more timely manner? Now, all of you are court professionals, so I realize my question is about to sound really stupid that I'm going to ask you. But let's say Patty Tobias and I both enter into your local jail with the exact same charges, except I have significant mental health issues and Patty does not. Who's more likely to spend more time in your justice system? I am. What are some of the reasons for that? Just 1 or 2 that you can think of off the top of your head. Acting out. So my behavior while I'm in custody may get me write-ups for rule infractions or other violations, so I may either lose time or get more time as a result. Exactly. My ability to cooperate, yes. Competency. So we start to see things like, there was a publication that has not been disseminated yet, but it was written by a group of psychiatrists, and the folks in West Palm Beach got to hear me talk about it last week, where a young man with very serious mental illness was inside of a grocery store and he started eating bananas. The store owner couldn't get him to stop. He obviously didn't have the ability to pay for those bananas, so he contacted law enforcement. Law enforcement came, attempted to intervene. Things escalated. He was placed into custody. The charges were for essentially shoplifting, for eating the bananas without paying for them. The issue of competency was raised. He, over the course of the next 2 years, spent time going back and forth between having competency evaluations and competency restoration, going back into the jail where his competency came into question again, and finally 2 years later he received credit for time served. Okay, so we can see how this has a very real impact on people with similar charges, but one who has significant mental health issues and another person who does not. So when we take that model, that sequential intercept model, and come into a community and do a sequential intercept mapping with it, really what we're doing is we're taking a look at some key areas. Where are there fragmented parts of the criminal justice behavioral health system as they come together, as they merge? We want to start to identify not only where the strengths in those systems are at as they work together, but also where are the gaps at? Where do people fall through the cracks? Where does the safety net miss people? We want to see where we can identify interventions that are needed based on those gaps. How do we streamline duplicative efforts that perhaps multiple organizations are engaged in? And really what the mapping does is shows how people move through your system from a criminal justice behavioral health perspective. So it's really a good illustration of what exists and how people move through your system. How many of you have heard of the fable of the 5 blind men and the elephant? 1. So do you think I can make it up, or are you going to hold me accountable? All right, so the fable goes something like this. There are 5 blind men living in a village, and they've had ongoing discussions about what does an elephant look like. And one day an elephant wanders into their village and they decide, aha, this is our opportunity to finally figure this out for ourselves. So they each approach the elephant and grab a different part. One grabs a tail and describes it as a thick, sinewy rope. Another grabs the leg and describes it as a really rough tree trunk. And they go around and do this description with each other. And what they decide at the end of it is, not only do they not have a better idea of what the elephant looks like, they're more confused than they were before they started. And that can oftentimes be what it's like in our communities with criminal justice and behavioral health systems. We know our piece of the system. I might know really, really well what reentry looks like in my community. but have absolutely no clue what's going on in the court system, or have no idea how law enforcement's interactions with people with mental health and substance use issues looks like in the community. And so what the model, but as we move down the road into the mapping does, is it allows us to speak a more common language. We start to learn each other's cultures, lingos, languages, how we interact, where the strengths are at, where the gaps are at across these 6 intercepts that you see up here. And I'm going to talk about these 6 intercepts next. I also, again, being from Nebraska and being used to dodging tornadoes every summer, like to use the filter model as an example of the sequential intercept model. You'll see up top where there's intercepts 0 and 1. It's the widest part of the funnel. And in an ideal community, when we go in and do the mapping, what we want to see are where are those early diversion opportunities for people. The more early diversion opportunities there are, the fewer people who are penetrating into being booked into jail and into the court system, we see as being better, especially for folks who are low risk to the community, who have significant behavioral health issues. So you can also think of this not just as a linear model, but also as a funnel model that ideally captures more people early on at diversion points. So let's talk about Intercept Zero here. And I want you to take careful note of how local law enforcement there, only about half of it straddles that Intercept Zero line, because as you're going to see as we move into Intercept 1, local law enforcement is also in there. But the idea with law enforcement involvement in Intercept Zero is different from their role in Intercept 1. The President's 21st Century Policing Report really did a good job of describing the dual roles that law enforcement officers have between warrior versus guardian. And so in Intercept Zero, when people are first in the community experiencing some sort of a crisis, if law enforcement is to get involved, which ideally in Intercept Zero they won't, that role of the officer is to really help identify where this person can access help at. Services, treatment, supports, hospital, whatever that might look like. As opposed to Intercept 1, when we move into there, the law enforcement officer is really faced with a tough decision. Am I going to try to help this person move back towards Intercept Zero? Or is there a potential law infraction that's taken place and now I'm going to be moving towards Intercept 2 where they're going to be booked into the local jail? So that report does a good job of really describing those dual roles of law enforcement. When we're doing a mapping, and we just did this in West Palm Beach here less than a week ago, I guess it was a week ago today we started the process. In Intercept Zero, and I want to come back to this box here real quick, that big box that says Crisis Care Continuum, one of the most important things that we're doing in Intercept Zero when we do a mapping is to help identify what types of services, treatment, and supports are available to people when they're experiencing a crisis, a mental health crisis, a substance use crisis. So what are those services? What's there? What's missing? And just as importantly, do people, whether it's me who's in crisis, whether it's a friend of mine, a family member, loved one, whoever that might be, do people know how to access these services, this array of services in my community without first dialing 911? And you would be surprised how many jurisdictions where the answer to that is no, people don't really have a good awareness of the services, or no, they don't really know how to access them without first having law enforcement assistance and dialing 911 in the first place. And you can see up here that a good crisis care continuum entails everything from low intensity services like peer support, or calling a crisis line, or calling my case manager, and moving up to things like outpatient therapists or hospitalization, and even longer term services like longer term residential services. So a good crisis care continuum in my community is going to contain an array of those services. And you'll see up here too, especially as you access the presentation, there are also publications and resources that you can access to get more details on these, and that's why they're included on those slides. One community that we did a mapping in 2016, Mecklenburg County or Charlotte, North Carolina, did a really nice job of taking that crisis care continuum work that we did with their mapping and breaking it out into 4 different categories. Those preventative pre-crisis services. So what is it that people can access before their issue reaches a full-fledged crisis? If they are in crisis but it's not emergent, doesn't require a hospital level of care, what are other types of services that are available? What services can they access when it does become a full-fledged psychiatric emergency? And then just as importantly at the end, what happens after the crisis is passed? If we don't do a good job of helping people access post-crisis care and services, what do you think happens? Right back in crisis again. All right, so we're just kind of seeing the circle repeat itself then. But it's also important that we take a look at what are law enforcement interventions at both Intercept 0 and 1 here to help people during those times of needs. So I'm sure most of you in the room have heard of CIT, or Crisis Intervention Team Training. That's obviously one tool that law enforcement has under their belt, that 40-hour or 1-week training that law enforcement officers learn more about de-escalation and what services and supports to access. Co-responder models, where we see behavioral health professionals who are actually employed by law enforcement organizations, and they respond to calls for services together. We see off-site support, and this is actually something I do back in my region in Lincoln, Nebraska, a 16-county area, where I've got my iPad up in my hotel room with me right now, so if tonight a law enforcement officer gets a hold of me, they can be half a country away from me, and I can do that off-site support over my iPad while they're in their cruiser with their tough book and the individual who's in crisis. So as we move into Intercept 1, again, the law enforcement officer is faced with a decision of, am I moving back towards Intercept 0 and helping this person access treatment services and support, or do we move to Intercept 2 now, where I'm looking at booking this person into the local jail? In your home communities, when you go back, one question to ask, especially if you have a CIT trained law enforcement staff, is what types of training do the 911 dispatchers get? Because all too often what we see are dispatchers who aren't well trained on doing triage of those calls as they come in and asking mental health questions, or perhaps they are trained, but there's not then a linkage to a CIT trained officer or some co-responder or mobile crisis response. So it's just as important, because the first point of triage are our 911 operators, to know what kinds of training are they receiving as well as those calls come in. We talked a little bit about CIT, so I'm not going to spend a lot of time on that. I'm sure most of you are pretty familiar with the training and what goes into that. The difficulty that we see, though, is that despite this training, despite these resources, despite these efforts, is that sometimes things don't always work out as planned. And so what we might find is that the person is taken to a facility for assistance, but they might not meet commitment criteria. I can't tell you how often at our regional crisis stabilization unit that serves 16 counties and 4 law enforcement organizations, where sometimes that officer has said to me afterwards, Travis, I felt like the person that I took there beat me back home faster than I got home after I dropped them off. So they may not meet that commitment criteria. The issue may be a behavior problem or not a mental health issue. It may be a medical problem. Things like diabetes can, if a person is having symptoms or a diabetic reaction, can mask mental health symptoms. It might be a substance use problem and not a mental illness. Some facilities, again, if your BAC is above a certain level, you can't go to that facility. You might have to go to a hospital first or a detox facility. As you can see from the next bullet point there, they might need to detox before they can really get that assistance. And then we all know what goes on with things like if a person doesn't have insurance, or if there aren't beds available and a law enforcement officer has to transport that person perhaps hundreds of miles to get somewhere else. But that big question down on the last bullet point is something that I want to address as we start to kind of move our way out of early diversion in 0 and 1 and head into Intercept 2 at the local jail. And that is, we all, especially people like me who have a background in mental health, we have a role in our communities to help law enforcement officers answer one key question, and that question is divert to what? All right, if I as a law enforcement officer and in the community with somebody in crisis, and I'm trying to decide what I can do to help that person out, but I have no clue where that person can go, or there's not a bed available, where do you think I'm going to take the person? To jail, right? I might come up with a trespassing or a disturbing the peace charge, because I want to know that this person's going to be safe, that they've got some place to lay their head down tonight, that they're going to get meals. And so it kind of comes back to that. We have, over the last several decades, viewed a potential solution, or at least a temporary solution to this problem, as we can just book them into jail. All right, so if we can't help law enforcement especially in that crisis care continuum, answer the question of divert to what, a very high percentage of the time that individual is going to be taken into the jail. So how do we make Intercepts 0 and 1 work? And really, as we're starting to see more services and programs and trainings come online, it really is, what do first responders, our 911 operators, our law enforcement officers, our EMS, our fire personnel who are responding to more and more crisis calls, what do they do differently based on their training and resources? But what do people like me do differently? Things like that off-site support or mobile crisis response. What do we do differently to help first responders so that the system does really change and we see fewer and fewer people with serious mental health issues being funneled into our local jails? So as we go around the country, what are some common gaps that we see in Intercepts 0 and 1 in jurisdictions across the U.S.? We see a lack of crisis stabilization units and other services like detox to take people to. I cannot tell you how many jurisdictions, when I ask the question, so if somebody needs to detox, where do they go to? And the answer many times is jail. That's where they go to detox. All right? So we see a lack of those types of services, a lack of sufficient mobile crisis response where trained professionals can come out to the scene and help law enforcement, and a lack of mental health or CIT training for 911 dispatch, like I talked about earlier. So these are some of the common gap areas in jurisdictions around the U.S. So as we head into Intercept 2, we're really looking at, now I as a law enforcement officer have made the decision to take you into custody. What's going to happen from the point that you hit the booking desk at the jail to the point where you have your first court appearance or arraignment or whatever you might call it in your home community? Now, I want to emphasize the importance because we're going to start to make the transition from early diversion to non-early diversion here pretty quickly. And really the importance as a community, when you think about that funnel model, the importance of identifying good early diversion opportunities for people who are low risk to public safety, low risk to return to court, et cetera. The study that was, is anybody here from Kentucky? Okay, so this study of 155,000 pretrial detainees in Kentucky that took place about 5 or 6 years ago. Really robust study. Really found a couple of interesting points. That low-risk defendants who were held even 2 to 3 days in jail were 40% more likely to commit crimes before trial. And then when held 8 to 14 days, those same low-risk defendants were 51% more likely to commit crimes 2 years after case disposition. So really we start to see what the negative outcomes and impacts are of low-risk people being in our jails, when the reality is, guys, they don't need to be there. All right, so the importance of finding those early diversion opportunities to connect people to is really important, not just in terms of their life outcomes, but also the outcomes for our community in general. The National Association of Counties, this study is a couple of years old, took a look at the jail populations within the 87% of the counties that actually owned and operated their own jails. And as we would expect, they found roughly 2/3 of those jail populations were pretrial defendants. And of those jails, those 87%, we found that only 40% are using some sort of a risk assessment to identify if people are low, moderate, or high risk. Of those 40% that did, what was really interesting is that 6 out of every 10 people were assessed as being low risk. And so it really does start to beg the question, as you've heard me kind of griping about, you know, what are we doing? Why are we looking at the jail as the solution, especially for people who are low risk to the community? This is the group that early diversion is all about. So what are some essential elements? Yes, sir.
Not releasing them as criminogenic.
Right. Not releasing them as criminogenic and looking at that R&R or risk needs responsibility piece. Right. So what are some essential elements when we talk about identification or Intercept 2 diversion? Because again, Intercept 2 really happens pretty quickly in most communities. I don't know about your home community, but from the time a person's booked into jail to the time they make that first court appearance, or in Lincoln, it's called arraignment, that lasts 24 hours max. So if you're going to divert somebody at that first court appearance, you've got to gather a lot of information quickly to make that recommendation to all the court system players who are either going to give the blessing or the denial for that recommendation for diversion. So we've got to have good identification and screening. And in a minute here, I'm going to whiz through a bunch of screening instruments that we recommend, or different types of screening that we recommend take place in jails. You need to have a court-based clinician that can be there to help assist court personnel on making those diversion recommendations. We need to look at recovery-based engagement. Again, that belief that recovery is possible for all people, but it's going to look different for each individual. And then finally, that there's a proportional response. So here's what that means. If I'm charged with something that I might serve a maximum of 6 months for, it's probably not realistic to think that you're going to put me in a diversion program that's going to last for 2 years. All right, so we're looking at a proportional response to what the potential sentencing looks like for a particular charge. All right, I'm going to go through this next piece quickly, so keep up here, okay? And if you have questions about any of these instruments, again, you can ask me at the end of the presentation individually, or you're going to have this presentation. You can get my card. The thing that I want you to be aware of with all these different types of screening instruments I'm going to go through is that we believe at Policy Research it's important to give jurisdictions resources that are available in the public domain, for one, so anybody can access them, but also that they're free. All right, so you don't want to have 20,000 people coming through your jail in the year and have me say, oh yeah, you should use the screening instrument that's going to cost you $2 each time you use it. Okay, so we want to make sure that it's available for free in the public domain. These are some sample mental health screens that do a really good job with both men and women. I will tell you up front that I'm partial to the brief jail mental health screen because we created it at Policy Research Associates. All right, it's a really quick, down and dirty, 3 minutes or less instrument that can be administered by anybody at the booking desk. It's 8 yes or no questions, and it has a referral rate of 11%. So here's what that means. Out of every 100 people that the screening is given to, 11 of them are referred on with the message of this person needs to be further assessed for a potential mental health issue. There's no screening instrument that diagnoses anybody, okay? This is recommending further assessment for a potential mental health issue. Of that 11% referral rate, what we find is that it's accurate out of about 3 out of every 4 men and 6 out of every 10 women. So for such a quick instrument, it really does have a good accuracy rate. So that's mental health. We have some recommended substance use screens if you're not already using one of these in your local jail. And here is also a couple of publications out of the Substance Abuse and Mental Health Services Administration that provides more details on these screening instruments, on their properties in terms of validity and reliability. I know that most jails are obviously doing a decent job of doing suicide prevention screening. All right, so obviously that's become a very important issue and certainly something that we recommend, and a safety plan for people who screen as being at higher risk for potential suicidal behaviors. Why do you think traumatic brain, and the folks from West Palm Beach can't answer this question because we talked about it last week. Why do you think it's important that jails screen for traumatic brain injury? Liability, sure. Yeah, liability is always a good reason to do that, absolutely.
Untreated, they're going to die.
Okay.
If there's a hemorrhage.
Untreated people who might hemorrhage would die, absolutely.
Throw off results.
Absolutely. We're seeing it, yes, ma'am.
They could also have, like in, if there's exposure and blast or the injury came from trauma, they could have some sort of traumatic.
Exactly, exactly. So we're seeing more and more veterans not only coming into our criminal justice system who may have a history of TBI, but if you think back to the trauma slide that I showed you earlier, I mean, guys, it's about time we start making, in the medical field we use universal precautions. Really in this field we should start talking about universal assumptions, and that is almost every single person that's coming into your local jail has some history of trauma. And one of the things that we know is that people with histories of trauma in a criminal justice system have probably taken blows to the head. All right, and so screening for things like traumatic brain injury is really important for a population of people who have such a high prevalence rate of trauma. And so speaking of that, the TBI, the identification and referral of veterans, your institution, your facility may be using the VRSS or the Veterans Reentry Search Service. It's a system that's available to your facility. It's web-based. Go on and you can look up if a person has a history of military service or not. So that identification of veterans can be really important in terms of diversion opportunities, linking them back to benefits and other resources. One of my favorite things that happened is we were doing a mapping in California, and there was a mother there affiliated with NAMI, National Alliance for Mentally Ill, and she said, I really like the model. I like what's illustrated in terms of the sequential intercept mapping, but there's something that I don't like about it. And this was before we created Intercepts Zero. This used to just be a 5 intercept model. And what it illustrated, or what it depicted, is that she said, it looks like my loved one first has to have contact with a law enforcement officer before they can get the help that they need. And that was really the primary impetus as to why we created Intercepts Zero in the first place. But they also took this a step further and created, through NAMI in California, this form that a loved one could fill out on the individual who is being booked into jail, and then it could be sent into jail staff. So that way the jail had a better idea of what was going on with the person in terms of diagnoses, symptoms, medications that they were on, service providers that they were working with. So it was really a way for those loved ones as community members to work as partners with the jail staff to help the person that they were, loved and was being served in the jail. So this was a really kind of neat form that came out of that. What are some common gaps at Intercept 2? A lack of early diversion opportunities. As we talked about, Intercept 2 happens really, really quickly. So sometimes that can be difficult for communities to keep up with. A lack of specialized supervision for people with mental health disorders on pretrial supervision. So you may have a pretrial services department to divert people to, but those officers may not have specialized training or specialized caseloads to work with persons with mental health and substance use issues. And then again, a lack of multiple screening strategies like we just went through. So it's really important that we look at in Intercept 2 is what's happening as that person's being booked into the jail, and what's being communicated down the line, whether it's pretrial, and what pretrial now shares with you as court staff in terms of making those decisions for early diversion here at Intercept 2. As we move into Intercept 3, the decision has now been made after that first court appearance that the person's going to remain in custody for a longer period of time. So really, the big things that we want to look at in Intercept 3 are what types of specialty or treatment courts, disposition courts exist within your community. So things like drug court, mental health court, veterans court, DUI court, that many of you, I'm sure, are probably very familiar with back home. And then also, what are those ongoing jail-based services that a person will have access to? So are there groups? Is there individual counseling? Are there other groups coming into the jail and providing in-reach services? What types of access to medications do individuals have? And what types of communication is taking place between jail treatment staff and community-based treatment staff that are serving the same person now? So it's really important, that we look at, and I know all of you do this in the court system, how we use criminal charges as treatment leverage, essentially that carrot that's being dangled in front of a person. Are there pre-plea diversion opportunities in lieu of further case processing? So do you allow people to access treatment or other types of specialty courts in lieu of that case being prosecuted further? Or are there more post-plea opportunities where perhaps a sentence is deferred or modified until you see how the person does? We're always big advocates for providing specialty court opportunities for people who aren't just necessarily facing felony charges or pleading guilty to a felony offense. I was at a jail in Texas a few years back and was talking to a gentleman through his cell, and he was a veteran, and he said, "You know what? Is there any way you think you can talk to somebody about me pleading my case up to a felony?" I said, why would you want to do that? He goes, "Because then I could get into veterans court. I can't get into it here with a misdemeanor charge." And so we want to make sure that we don't want to see people with lower level charges languishing in jail longer than people with higher level charges because that type of service is not available to them. But consequences that have to be considered, especially when you're looking at felony treatment courts, especially if you require a person to plead guilty to a felony charge before they can participate in that court. Things like housing opportunities that may no longer be availed to them, benefits that they could apply for, how it impacts voting. Is yours a community that requires people to, you've heard of ban the box, I'm assuming, where they have to check, yes to that. I've been convicted of a felony offense before. So these are all considerations that we have to take in the court system as people are being moved through the specialty courts. We also want to look at, and this probably shouldn't come as a surprise to anybody, this is 3 years old now, but in 2016 the National Association of Drug Court Professionals took that inventory of what types of treatment courts existed throughout the United States. And it wouldn't come as any surprise, since we got our genesis with adult drug courts, that by far we have the most number of those around the United States, followed by mental health courts, and you can read on down the line here. So what are some common gaps at Intercept 3? When we look at jail-based services, there are a number of jails that still aren't doing screening for veterans or people with military service. Medication continuity is a huge one. So if I come into your jail on a certain medication, does your formulary within your jail dictate that I can no longer be on that medication and I've got to go to something else? Now, the rest of the story on that gentleman that I told you about earlier, who spent 2 years going back and forth between competency restoration, he would go to the facility where his competency was being restored and be put on one medication. He'd go back to the jail where that wasn't part of the formulary, and he'd go off that medication. And so, finally, once things got figured out, that problem was disrupted, and they were able to give him credit for time served. But the formulary can really cause an issue for people, especially if they're on a medication that is working for them. The last bullet point there about there being insufficient data, I don't know how good of a job your community is doing in collecting data, baseline data on people with serious mental health issues, but we've got to know. We have to know who is coming in the front doors of our jails and is coming into our court system in terms of the issues that they're dealing with. We've got to have good baseline data that says this is the percentage of people coming in who have serious mental health issues. This is the percentage of people on psychotropic medications. We need to have that good baseline data. Under courts, really the only one I'm going to touch on is the over-reliance on treatment courts. There are some communities that we've gone and done mappings in where there's very little going on throughout the first 3 intercepts, Intercept 0, 1, and 2, early diversion, because that community says, we've got robust treatment courts in Intercept 3. When you think about that funnel model, we don't want people making it all the way to Intercept 3, especially if they don't need to. It doesn't do you, your system, your community, or that person any good if they have to spend that much time involved in the justice system before they can finally have a diversion opportunity in Intercept 3. So as we move into Intercept 4, and we'll begin to kind of wind down here, we're really looking at what happens at that point of re-entry for people as they're moving out of the justice system and back into the community. So I have a flair for the dramatic sometimes when I'm presenting, but if I were to say to you something like, would you agree with me if I said that good re-entry really is a matter of life and death? How many of you would say, yes, Travis, I agree with the dramatic way that you asked that question? A few of you would. Okay. So there was an older study done in Washington State that was published in the New England Journal of Medicine that followed 30,000 people being released from the prison system in Washington State. And what that study found was that 443 of them died in a period of less than 2 years post-release. Their death rate was 3.5 times higher than that of the general population, and the leading causes of death were drug overdose, heart disease, homicide, and suicide. So really, there are those types of things that we can help people, if we do good reentry and discharge planning, get connected with the right services, treatment, supports, peers, etc., to help avoid some of these issues. Because what we find is that it's much more common, and in jails, obviously, we're focused on trying to prevent things like suicide attempts. But what we find is that it's much more common for people to kill themselves, commit suicide post-release from incarceration, than it is while they're incarcerated in our jails. And we start to look at what are different types of reentry models. When I was working in the state prison system in Nebraska, we were actually really advanced, and we had $100 in a bus ticket instead of $40 in a bus ticket. But we're seeing that those times are changing, thankfully. But what happens with good reentry? Reentry begins at the time the person enters the facility in Intercept 2. The population at the jail is being sorted out by risk and need. We're using validated screening instruments, not only for mental health and substance use issues, but also taking a look at risk. And then we're focusing on what we're finding from the literature is that there are key points in time post-release that we really need to be helping people with, and that's 24 hours, 1 week, 3 months, and 9 months when people tend to be at higher risk. Here's essentially what this is saying without reading the slide to you guys. The type of reentry model that works best is in reach. So if I'm working with a community-based organization that's going to help Patty when she gets out, it's best if I or somebody from my organization can come into the jail and say, "Hi Patty, I'm Travis. We've got an appointment in 2 weeks. I'm really looking forward to working with you and seeing you." So that way there's that face-to-face interaction rather than giving somebody a business card or a sheet of paper that says you can go to these organizations when you get out, whatever the case might be. Good case management, good system navigation is critical. You can see all the needs that people with behavioral health issues have as they're coming out, and usually the multiple systems that they have to touch upon. Here's what I can tell you. I've lived in Lincoln, Nebraska for over 25 years. And I've been blessed that I haven't had to deal with significant mental health, substance use, trauma, family issues, etc. But if I was getting out of my local jail and you told me I had to access all these services and these systems, I couldn't do it. Now think about if you have competing stimuli in your head that tells you people are out to get you, or you have really radical mood swings. And we're telling you these are the things you need to do to stay out of the justice system. Here's a piece of paper, go do them. An interesting tidbit about this picture, the first time I showed it to my kids, there were 2 questions that they asked. Any idea what one of them might have been? Why does that thing have a cord coming out of it? That phone, what's that thing? And then who's the fat Batman? Batman doesn't look like Adam West did, you know, back in the day. Another resource that we created, and again, you can get access to really easily, is this, I'm going to show it to you here. Oh, I don't have a picture. It's hard to see here. The APIC model, Assess, Plan, Identify, Coordinate, is broken out into 10 reentry areas. So for facilities that are doing reentry planning for people with behavioral health issues, there are 10 key areas of discharge planning and reentry back into the community. Those 10 key areas are broken into this Assess, Plan, Identify, Coordinate model, or the APIC model as we call it. So we do have resources to help jails with good reentry planning and looking at things like medication-assisted treatment for people, access to public benefits like SSI, SSDI, outreach, access, and recovery. That's another department that we run at Policy Research Associates across the U.S. is helping people, helping case managers, helping peers and navigators make good first applications to Social Security that have very low rejection rates. Here's that reentry checklist that's broken out into those 10 categories based on the APIC model. And again, these are all free. And there's multiple copies attached to this reentry checklist, one for the person, one for the facility, another for the community-based provider, et cetera. So we want to make sure that we've got good resources to give people across these 10 domains that you find on the reentry checklist. So we're going to move into Intercept 5 here, where really what we start to look at is what happens when an individual is now going to be back into the community under some sort of supervision, whether that's parole or probation. Because as you see from this slide, if you look at parole and probation on the circle graph, 2 out of every 3 people that are under some form of correctional involvement are out in the community. Most of them on probation, but a decent percentage on parole. And so it's really important that we look at what are the resources and the supervision that's available to help at least reduce the chances that a person's going to recidivate back into the justice system, because we've seen all too often that this is what it looks like for a probation or parole officer underneath the hundreds of people that they may be responsible for supervising at any one time. So there are publications out there that talk about the promising practice of specialized caseloads and the specialized training that those supervision officers receive. We have probation resources. We have resources for peer specialists and people who help in the community when a person's under supervision in terms of recovery supports for persons with mental health, substance use, and trauma disorders. We know that things like wellness recovery action planning helps individuals that we're talking about in this population identify their triggers, who they can go to for help, what types of support that they need. And we also know Guys, across intercepts, the 6 intercepts that I've talked to you about today, housing is the #1 issue that usually comes up in communities. And we know that good, stable housing is also a form of good treatment and support for people to help reduce their re-involvement in the justice system. And you can see some of the common gaps here. You don't need me to read them to you while you're taking a look. So we've got about 5 minutes here. Please don't ask me any difficult questions that I can't answer in front of a large audience, but I'd be happy to try to entertain your questions, and if I don't have an answer for you, I can at least get you linked to a resource afterwards. Okay? Any questions that anybody has? Yes, sir. We've got a microphone coming right here, sorry.
Just a quick question, thank you. When you go in, I assume that your company would go into an area and analyze that area, see where the gaps are, see where the needs are. What is your experience on which entities are normally taking the lead in dealing with issues like that? Is it usually the corrections environment, the court, probation, or is it generally across the board collaboration?
And that's a fantastic question, and it really does differ from community to community. So we do these mappings under 3 different umbrellas in our company, and one of them is a competitive solicitation that goes out through the Substance Abuse and Mental Health Services Administration each year. In fact, the one that we're getting ready to do in Alabama at the end of August is through that. So really the lead is the organization that applied for that. But what we see in other jurisdictions that reach out to us and say, hey, we want to have you come in and doing this, oftentimes it can be the courts. And so we talk about 2 really important things that I can usually, by the time I've left, know if, with fairly decent accuracy, if a community is going to be successful or not in moving this effort forward based on 2 things. One is there some sort of a formalized planning body, a criminal justice behavioral health planning body that exists there that's going to take this under their umbrella. And it doesn't matter what you call it, but it's a cross-representation of criminal justice behavioral health professionals that this work can fall under and have a home. The second one, I suppose I should hold 2 fingers for that, is there a key champion in that community that says, this is so important to the work that we're doing? And by champion, I mean somebody who's got some teeth to get people together. Oftentimes that's a judge. Sometimes it's an elected sheriff, a police chief, or some sort of perhaps a county board member or city council person. But you may or may not be surprised to know how often that is a judge who says, we're getting together, this is important, and here's what we're going to do about it. If I invite somebody to come do that, hardly anybody's going to respond. If a judge invites somebody to come do that, you get a pretty good response rate. So it's really important to have that champion. But it's a good question. Probably have time for one more question if anybody has one. Okay.
I was just going to ask if you were going to be able to make your PowerPoint available as part of your presentation on here.
Yeah, it sounds like it's going to be, there's a conference
Yeah, in the app.
Yeah,
Okay.
and so it'll be on there.
Okay, great, thank you.
Yeah, you bet.
Speaking of
Yes.
the app, make sure you fill out your session evaluation at the end. Thank you.
All right, thank you for your time, everybody.